So let's talk about the aortic valve for a minute. So this is your aorta. Remember, this is the left atrium, mitral valve, left ventricle, aorta, and the aortic valve right here. So whenever a person has stenosis, in this case, let's say they have aortic stenosis, the cath pressure tracings are going to be acquired from the chambers proximal, which is right here. Remember, the chamber before the valve is the proximal chamber, in this case, the left ventricle, and the chamber that is distal, and the distal chamber to the aortic valve is the aorta. And they're going to get the peak pressures, and then they're going to be compared to each other to get the gradient. So the gradient will be the pressure in here minus the pressure in here. That's what that is. Now, usually the chamber that is proximal to the stenosis is going to have high pressure. The pressure is going to be high. The chamber that is distal to the stenosis, the pressure is going to be low. So the pressure is going to increase here because the mitral valve is opening and letting blood to the ventricle, but the ventricle is not pushing out the blood quick enough to receive the other blood. So which means it's struggling to push out, but it still keeps getting more. So the pressure increases in here. But there's barely any blood here because this is stenosis, and it's blocking, like the valve is not opening the way it's supposed to open. So due to that blockage, only a small amount of blood is leaving. So the pressure right here is minimal. So other additional cath calculations that we get is the mean transvalvular gradient and the mitral valve area. And we get that by tracing, like in short axis, this. When you see the mitral valve, it's called mitral valve planimetry, but this will be like when you get into short axis and you look at the mitral valve and you're at the level of the mitral valve, you will trace that, and then you can get the aortic valve area using the continuity equation, which we'll talk about later, specifically when we talk about the aortic valve by itself. So we're also going to want to evaluate regurgitation. If the person has regurgitation, we're going to evaluate the function, and we're going to rule out any type of coronary artery disease. Now, if this situation is really bad, sometimes we can do what's called valvuloplasty, and that's when we use a balloon and put it into the valve and kind of inflate the balloon to help like break up the how small the valve is to increase like the space so the blood can travel more freely. But you can't do this all the time because it depends on the type of stenosis that the person has, because you don't want a piece of that breaking off, traveling through the aorta and giving the person like a stroke. So sometimes this valvuloplasty can be called valvulotomy. Sorry, I never pronounced that right. And it widens the heart valve that is narrowed, and it's used, the valve has to be pliable. You can't use it for valves that has like a bunch of plaque on it. So it has to be if the valve was just like smaller and you're plying it open and it doesn't have calcifications. If it has calcifications, you cannot use valvuloplasty at all. So I'm gonna put this picture over here for a moment, and I'm gonna show you how this works with a cath. So let's say the person has stenosis. And you take them to the cath lab. So a normal pressure is going to look like this. There's not going to be a massive difference between the pressures in the left ventricle and the pressure in the aorta. So keep that in mind. So we're now going to take this and we're blowing it up, and it looks like this right here. So it's this section right here that we've blown up for somebody who has aortic stenosis. So before we can interpret this, we have to ask ourselves a few questions, and we need to answer those questions. And the top 4 questions we need to ask are these questions right here. First, what is the scale on this graph right here? And so the scale here is 50 millimeters of mercury, 100, 150, and 200. That's the scale. So the scale ranges from 50 to 200. Question 1 is answered. Number 2, what pressure tracings are on the diagram? So what are we looking at? So what we're looking at is the pressure in the left ventricle, which is this green right here, and the pressure in the aorta, which is the blue right here. So we've answered question 2. Question 3 is, what valve lies between those two chambers? So what valve lies between the left ventricle and the aorta? The aortic valve right here. So we just answered question 3. And the last question is, what is the difference between the two tracings and how do they compare to this normal tracing right here? So when you look at this tracing and you compare it, remember, to just this part right here, you're going to notice that this left ventricular systolic pressure right here is elevated, and it is much higher than the aortic systolic pressure right here. But in the normal, there isn't a big difference. When the person has stenosis, though, there is a big difference. So that's going to create that transvalvular systolic gradient. And whenever we see this then in the cath lab, is consistent with somebody who has aortic stenosis. So if you compare the two tracings, if you look at this and compare it to this, in a normal patient, there should not be a significant systolic gradient difference between the left ventricle and the aorta. So that's how we read that. Now, I'm going to take away this picture just so we're looking at just the tracings. So again, in the cath lab, we're now going to include echo, but let's leave the echo alone for now. We're going to ask these questions again. Here they are. So what is the scale on this graph? 50 millimeters of mercury all the way to 200. So 50, 100, 150, 200. What are the pressure tracings that we're looking at, right? We're looking at the pressure in the left ventricle, and we're looking at the pressure in the aorta. So what valve lies between the pressure, these two pressures? It's obviously the aortic valve. And what is the difference between this tracing and this tracing? In the normal one, there's not a high difference. And the aortic stenotic one, the left ventricular pressure is much higher than that pressure in the aorta. And so this is consistent with the person who has stenosis. Remember, the way we find aortic stenosis for echo is we take the peak velocity and the mean pressure gradient, and we're going to get them using continuous wave Doppler. So you put the continuous wave Doppler in 5-chamber. I apologize about that. I just received an Amber Alert. Anyway, you put the continuous wave Doppler in apical 5-chamber and apical long, but remember, you also want to get that LVOT diameter when you do your plaques measurement. So anyway, you turn on the continuous wave Doppler in apical 5-chamber and apical 3 or apical long, and you get this waveform that's going to be below the baseline. It's going to be pretty high if they have severe stenosis. So what you're going to do is trace this right here. And when you trace it, what we call that is planimetry. That's what tracing is. So again, that maximum pressure gradient is going to be calculated from the peak velocity, and we're going to use the modified Bernoulli's equation that we just talked about earlier. So again, we will cover this in detail when we talk about aortic stenosis. So MS is meters per second, and it's how we calculate aortic stenosis. If the number is greater than 4 meters per second, it means that the person has severe aortic stenosis. If the blood pressure is greater than 40 millimeters of mercury, it means the person has severe stenosis. So remember this modified Bernoulli's equation, 4 times the velocity squared. That's how we're going to get the pressure gradient. This person has 5 meters per second, which definitely means they have severe stenosis. You're going to put that in here. 5 times 5, because you're squaring it, is 25, and you're going to times that by 4 to get that 100 millimeters of mercury. It's very bad. All right, so now let's talk about mitral stenosis. It's very similar to what we just talked about. The process is literally the same. So we're going to look here, right here, because we're going to answer these questions right here. So number 1, what is the scale on this graph right here? It goes from 10 to 30 millimeters of mercury. 10, 20, 30. That is the scale. So what pressure tracings are we looking at right here? We are obviously going to be looking at the left atrium at this point, right? And the left ventricle at this point. So we're looking at left atrium versus left ventricle. So the region of interest for this one is right here, and it's been blown up to look like this right here. So let's get to this little picture. A normal valve, it opens, there's no issue. That's why the pressure gradient is low between the two. When a person has stenosis, their valve is going to be thicker and it's not going to open properly. So what's happening is there's the pressure over here in the left atrium is going to be much higher than the pressure in the left ventricle. But let me backtrack for just a minute. Once we're done with this, I'm going to talk about something new with you guys. So now we have the scale, we have the pressure tracings, and we have the the valve. Obviously, between the left atrium and the left ventricle lies the mitral valve, and in this case, it's stenosis. It has bad stenosis because it's not even opening when you compare it to the normal valve. So what is the difference between the two tracings, right? And what we're going to find out is the mean left atrial pressure is elevated and it's greater than the left ventricular diastolic pressure. So that's going to create that transvalvular diastolic gradient across the mitral valve. So whenever we see this, it means that like if the pressure, the difference in a normal one is not that different, but right here it's greater. That LV pressure is less than the pressure in the LA. The LA has much more elevated pressures. But the reason why that is because the valve won't open to let the blood out. So this is consistent for us with mitral stenosis. Now, mitral stenosis, the severity scale is like 5 to 10. And if it's greater than 10 millimeters per, if it's greater than 10, then we're looking at, if it's greater than 10 millimeters of mercury, I'm sorry, you guys, I'm tired, I can't speak today. If it's greater than 10 millimeters of mercury, it means that the person has severe mitral stenosis. 5 to 10 millimeters of mercury, if it's less than 5, it's mild. 5 to 10 is moderate. Greater than 10 is severe. So sometimes we can use the pulmonary artery systolic pressure. If we're using the pulmonary artery, the mild mitral stenosis is less than 30 millimeters of mercury, and severe mitral stenosis is greater than 50 millimeters of mercury. But normally they do that more in the cath lab. Again, we will talk about these individually when we get to chapter 8. So if you don't quite understand anything now, you will understand it when we're done. But first, let me talk about this pressure halftime. When you put the, remember in echo, we put the gate in 4-chamber at the tips of the mitral valve, and then we turn it on, and it gives us this E wave and the A wave. That is a normal thing. The E wave is normally going to be higher than the A wave. But if the person has stenosis, you are going to turn on continuous wave Doppler. It is going to give you an E and an A wave, except this time you're going to measure what we call the pressure halftime. And what the pressure halftime is, it's kind of like the deceleration slope, but we're not measuring that at that point. So what the pressure halftime is, it's the time it takes in milliseconds for the mitral valve gradient in early diastole to reach half of the maximum value. So you're not going to the baseline, you're just going from the E wave, the peak of the E wave all the way to where the A wave begins and stopping right there. And then to get the mitral valve area, you're going to do planimetry and you're going to trace right here. Trace just the E wave all the way around, and it's going to give you the mean pressure gradient while giving you that maximum pressure gradient. But again, it's easier when we do this in lab. This looks confusing, but it'll make more sense because I'll go over it in lab. Please remind me. So if the person has regurgitation, right, that's when there's like the flow is leaking back to where it just came from when the valve is closed during appropriate cardiac cycle. So what Cath is going to be able to tell us is if the person has regurgitation, how bad it is, and what is the cause of that like regurgitation. And we can use aortography And what aortography is, it detects aortic insufficiency. And how they do that is if they inject the contrast, and that injected contrast leaks from the aorta through the aortic valve in diastole. Remember, in diastole, the aortic valve is supposed to be closed. So if it leaks through the aortic valve in diastole back into the left ventricle, it means the person has aortic regurgitation or aortic insufficiency. Now, they can also do ventriculography. That's where they put contrast in the ventricle, and it'll detect if the person has mitral regurgitation or mitral insufficiency. Because what will happen is that injected contrast is going to leak from the left ventricle and through the mitral valve in systole. Remember, in systole, the mitral valve is supposed to be closed. So if the contrast agent leaks from the left ventricle through the mitral valve back into the left atrium when the valve is closed, it means that the person has mitral regurgitation. So we can also get like regurgitant volume, pressure tracings, and we can also evaluate cardiac function to rule out coronary artery disease. All this sounds like a lot, but I promise you'll get it over time. And of course, echo is used in conjunction with the TEE, which is the transesophageal echo, a stress echo, and a Cath tracing to give the patient the best diagnosis possible. We just want to give them quality assurance. You don't just want to do one exam and say, yes, you have this. They do several exams so that when they make a diagnosis, it's a correct diagnosis. It is not optional. It is required of every accredited lab. And so the correlations are going to be used to compare to each other so they can give that patient the best information that they have on the patient's pathology. Other things that they use are nuclear studies, and it can tell the doctor if anything, like let's say they did surgery, it'll let the doctor know if the surgery was successful or if it didn't go well, or if the patient continued to have symptoms, why they would continue to have symptoms. So let's talk about aortic stenosis and aortic regurgitation for a moment. At this point, you should understand this one right here on the count of we've talked about it. Remember, it's always connected to that normal flow. So you're going to notice that there'll be like a decrease in the aortic end diastolic pressure and an increase in the left ventricular end diastolic pressure, because the aortic regurgitation is going to leave the aorta and go back through the aortic valve into the left ventricle in diastole. Now, whenever you have severe acute aortic regurgitation, there's going to be an equalization of the diastolic pressures. So the pressures in diastole are going to equalize, and the LV systolic pressure is going to be elevated, and it's going to be greater than the aortic systolic pressure, which means that the person has aortic stenosis. Again, if there's regurgitation, the pressures are going to equalize, and the pressure in the aorta is going to be lower than the pressure in the left ventricle. Now, if the person has stenosis, the pressure in the left ventricle is going to be higher than the pressure in the aorta, but it is because the valve is not opening properly, not because of leakage. So remember, the first thing that happens when a person has regurgitation, there's going to be that volume overload. So it's going to lead to pressure overload, but what happens first is a volume problem, because the volume of blood that was supposed to have left came right back into the left ventricle, and because the mitral valve is still sending blood to the left ventricle, that pressure increases, but the first thing that's going to increase is the volume of blood. When you have stenosis, however, it's the valve itself that has an issue, so the pressure is what's going to elevate first. There's no leakage. It's just that the blood can't leave. So we use continuous wave Doppler for aortic regurgitation to get that peak velocity, and then we use the pressure half time. Now, for stenosis, for the aortic valve, the flow is going to appear below the baseline. For aortic regurgitation, the flow is going to appear above the baseline, and you do the pressure half time just like it's shown right here with the slope. So that's all I want you guys to keep in mind. Now, for this mitral regurgitation stuff, I don't want you to worry so much about this because this is more cath lab stuff than for us. And A few things I do want to talk about, though, is the pulmonary capillary wedge pressure, and I'll explain that when we get to the lab, and the V wave. So I'll talk about that here in a minute. So the pulmonary capillary wedge pressure, let's start with that. It gives the doctors an indirect estimate of left atrial pressure. That's why it's important. So what they do is they're going to use a catheter and move it all the way to the pulmonary artery, like the main pulmonary artery, and they're going to inflate, there'll be a balloon attached to that catheter. Once they reach the main pulmonary artery, they're going to inflate that balloon, and wherever that balloon inflates and lodges, they're going to take the pressure there. You can't do this in echo. This has to be done in a cath lab. And that pressure is what that pulmonary capillary pressure wedge pressure is. And it tells the doctor an indirect estimate of left atrial pressure. So again, we insert a balloon-tipped multi-lumen catheter. Sometimes they call it a Swan-Ganz catheter. They're in through a vein, either the jugular vein or the femoral vein, and they move it all the way to where the pulmonary artery is, into a branch of that pulmonary artery. And this V wave right here, whenever you see like an elevated V wave in the left atrial or like pulmonary capillary wedge pressure, it indicates the person has mitral regurgitation. So whenever you notice an elevated V wave, it means the person has mitral regurgitation. So the V wave in the left atrial pressure, or the pulmonary capillary wedge pressure, it represents left atrial filling when the mitral valve is closed. So this V wave represents how the atrium fills, like fills with blood, while the mitral valve is closed. If the person has severe mitral regurgitation, the V wave is going to be severely, like very accented. So it's going to be significantly higher. Now, when a person has acute mitral regurgitation, the left atrium does not have enough time for the blood that's coming back to squeeze it all out. So that's going to cause an increase in the left atrial pressure. So the LA, as in the left atrium, is going to try to compensate for the additional flow by dilating, meaning getting bigger. And over time, dilation is going to help prevent the left atrial pressure from rising. Keep in mind, this is temporary. So the left atrial enlargement is beneficial and well tolerated initially. But if nothing is done, mitral valve, it's going to get worse, and eventually the person is going to have heart failure if nothing is done. Now, sorry, you guys. That's the main things that I want you to keep in mind about that. Just like how there are reasons why we would do the situation, go to a cath lab, sometimes we can't do a cath if the patient is not a good candidate. Now, these are the reasons why we would not do one for the patient. If they have an active gastrointestinal bleed, if they've had acute renal failure is the kidneys, an acute stroke, allergy to any type of radiographic contrast, severe anemia, severe hypertension, or ventricular arrhythmias. That's when the heart is beating irregularly. So some of the risks would be like the patient could have more bleeding than what they would expect. They could become infected because remember they are inserting something in you and they're making an insertion in your skin. You could injure the nerve or the blood vessel. You can create, like when they do a cath, they could actually create arrhythmias if the person didn't have one before. It could cause the person to have cardiac tamponade, which we should have talked about. That's when the person's heart fills with fluid or the pericardium, and it starts to press or apply pressure on the heart. The person could have low blood pressure. They could have a bad reaction to the contrast agent, which could damage their kidneys, and that kidney could eventually fail from that contrast. It could give them a stroke, and also the person has a potential to get a heart attack. Now, all these things are obviously bad. You can see why the doctors don't just do cath all the time. That's why you want people to always take better care of their health and eat better and eat right. Because once our coronary arteries are clogged, obviously, look at this list of problems. It can cause a lot of problems for us. All right, you guys, In lab, I'll talk about the pulmonary capillary wedge and all these things to kind of help you guys get a better understanding of what we just talked about today. I know it's a lot, but I appreciate you guys, and I appreciate all the effort that you guys are putting in, and I will see you guys